Then you have hormonal drugs. So with hormonal drugs, yes, that's right. Let's see, beta 1 and beta 2, heart and lungs. Yes, that's correct. So then with hormonal drugs, you have parathyroid agents, right? Parathyroid agents. So these are drugs that's used to treat disorders that affect the patient's calcium levels, right? So this can either be anti-hypocalcemic drugs, so meaning that it stops low calcium levels, or anti-hypercalcium drugs, which helps to treat high calcium levels, and that's going to be characterized into biphosphonates and then or calcitonin. Then you have pituitary agents. So these are drugs that affect the anterior pituitary hormones, right? So which mimic or antagonize the effects of specific pituitary hormones. So they're used as a replacement therapy for diagnostic purposes and for blocking the effects of anterior pituitary hormones. So a very good example of this is somatropin. They end with tropin. All right, so with the anterior pituitary hormone, that's the most commonly used pharmacologically is a growth hormone, which is GH. So pretty much they're treating patients who have they can have gonadotropin, which is pretty much where the testes don't drop, like they have problems with their growth hormone. So that's why we're giving this medication. Reproductive hormones, this can be female sex hormones that can be used to replace missing hormones or to decrease the release of endogenous hormones. So with women, they can receive estrogen or progesterone, especially if they are on menopause. Men, testosterone. Some of these names are called Duratest or Testoderm. And this is the primary natural androgen and is the classic androgen used today. So it's used for treatment of certain breast cancers, hypogonadism, right, which is hypogonadism, which is a condition where they have undeveloped testes. All right, so these are some of the different drugs that we're giving. My voice is low? Okay. So these are some of the different types of medications that we're giving them. Okay, so then you have neurological drugs. All right, I'll try and speak into the mic more. So you have neurological drugs. So this is with neurological drugs, there's a lot that it can stem from. So there's anti-myasthenic medications, which pretty much treats myasthenia gravis. Anti-Parkinson medications, which is going to treat Parkinson's disease. And so, the thing about one thing I want to mention is that myasthenia gravis, Parkinson's disease, right? Both of them are not curable. So it's pretty much to manage their symptoms, right? To help to reduce the symptoms, but it can't actually cure the diagnosis. Then you have anticonvulsant drugs. So this is, like you got Dilantin, phenytonin. So anticonvulsant drugs, there's a lot that stem from this category, but they're used to treat seizures, patients who have epilepsy, which is chronic seizures, right? So with these ones, we want to really be careful when giving them, especially to patients that are like elderly. So these are your anticonvulsant medications. Then you have antipsychotic drugs. Antipsychotic drugs. This is going to be, for example, Haldol, very good example of one. And these ones helps to, treat psychosis, right? So if they're having hallucinations, they're having psychosis episodes, those would be some very common examples. Central nervous stimulants. So with central nervous stimulants, these central nervous stimulants, there's actually a lot that falls under it, but central nervous stimulants is a lot. It does cover a lot of these drugs already within this category. So central nervous stimulants can include actually like bronchodilators. These are medications that help to stimulate or increase the activity in the neurological system, which can include anti-Parkinson's medications, can include bronchodilator medications, non-opioid analgesics. So these medications help to treat patients. So these ones help with mild to moderate pain, and like Norco, right? They come. Oh, sorry, not Norco. Like ibuprofen, right? So these ones, they're not going to have serious adverse effects or potential serious adverse effects, but they're still used to treat pain. And sometimes they can have problems with if they take too much of it, like bleeding, right? So Tylenol, right? So you're gonna learning as far as like with these non-opioid analgesics, they're not as they don't have as much serious adverse effects as opioids, right? But they're still used though as a form to treat patients who are in pain. Opioid analgesics, though, these ones we're going to use to treat pain, like serious, severe pain, right? So like moderate to severe pain. So with these ones, we're going to see medications such as Norco, fentanyl, Dilaudid, morphine, right? So these are all opioid medications. With our opioids, there's a much higher risk with administering it, right? Much higher risk, because here now we're going to begin to see patients who they can become sedated, meaning that they're very like they can be harder to arouse if they're receiving too much of it. They can develop a tolerance to the medication too, meaning that they need more than they did before. But the biggest thing though is that the patient can become very sedated, and that alters their level of consciousness. So you have to really monitor the level of consciousness more closely. Patients on opioids also, they will experience constipation, because that's the effect of an opioid administration. All right. So with opioids, there's a lot of different types of opioids, and this is some of them, but they have a much higher risk for adverse effects. So that's why we have to monitor the amount that we give. We have to be more careful with patients that metabolize more slowly, right? Patients that have hepatic failure, renal failure, liver failure, they have a higher risk for overdosing on the medication. Yes, very good. Let's see, George Congenton, really good. That would definitely be an example for like anti-Parkinson medication. All right, so these are some of the neurological medications that you want to, as far as the classifications that you want to be familiar with. Then you have endocrine drugs. So with endocrine medications, there's different types of endocrine medications aside from only the ones that treat diabetes, but we have adrenocortical drugs. So glucocorticoids. A very good example of this is dexamethasone. So you definitely want to spend time learning about this one, because the thing about glucocorticoids is that they will cause the blood sugars to go up. So even if they have diabetes or they don't have diabetes, right? So it's going to cause their blood sugar levels to rise. So we have to, even if they don't have diabetes, we're going to do AC. We're going to check we're going to do active checks with these patients if they're on glucocorticoids medications. Anti-diabetic medications. So here I'm referring to oral diabetics, right? I'm referring to, oh, okay. Okay, thanks for letting me know, Evelyn. Okay. I was like, hey, George. Okay. That's funny. Okay, yeah. So these are your oral diabetic, your oral hypoglycemic agents. So you have alpha glucosidase inhibitors, biguanides. Biguanides, the most common one is metformin. Dipeptidyl or peptidase inhibitors, human amylin, incretin mimetics, meglitinides, and then also thiazola denedionides as well. So those, all the ones I just listed under the anti-diabetic drugs, they're all oral medications. One of the things that you want to be aware of is that these drugs don't typically cause a sudden drop in their blood sugars. It helps to just to give it a good maintenance. But we usually still give it though, prior to meals, or within about 15 to 30 minutes of them eating their breakfast, lunch, or their dinner. You also have glucose elevated agents such as glucagon. So that's what we give patients who have very low low blood sugars. They're in hypoglycemia. Then you have hypothalamic agents, right? So, or agonists. So agonists and antagonists. So example of this, goserelin, degrelix. Those are some examples of patients of hypothalamic agents. Also insulin. We all know about insulin. Insulin, you got to be familiar with, rapid acting, short acting, intermediate acting, long acting, right? So you got to know the different types of insulin, and then you want to also be familiar with the onset, the peak, the duration. That's very important, right? When it comes to how to correctly give insulin, or what to expect from, because you gave the insulin. Parathyroid agents, I talked about this before. Some of them, they fall under the same category as far as this being also an endocrine drug. So biphosphonates, calcitonins, the pituitary drugs between like I said, the growth hormone, somatropin, excuse me, and then also sulfonylureas. So an example of this is going to be glyphosate. So this is going to be for patients who do have functioning beta cells. So as far as with this one, if you're familiar with, right, when it comes to this is why it's important that you understand the difference between type 1, right, and type 2, because with type 1 we're seeing a destruction in the beta cells, right, but with type 2 we're seeing more of a resistance to insulin. So with sulfonylureas or glyphosate, we're going to give it to patients who have type 2 diabetes. Then you have thyroid agents, so levothyroxine, like Synthroid, as well. So you want to be familiar with the thyroid drugs, right? So what you're learning with these medications, you're learning what group they fall under, which I mentioned here, and then also they're all, well, except for insulin, they're all given orally. How do we give it? Do we give it differently? Like, as far as, do we give it with meals? Do we give it on an empty stomach? So, like, for example, with Synthroid, we usually give it in the morning, early in the morning, like around, I remember I used to give it at 6 a.m. to all my patients. And the reason why is because the side effect is that it can cause insomnia. So we try to give it early in the morning to minimize that side effect from occurring. Right. So you're learning what each of them fall under. You're learning what they do. You're learning what the side effects and the adverse effects for each of them are that I'm listing for you here. So that way and then also, like I said, insulin is a little bit different because insulin, you want to also know the onset, the peak, and then also the duration. All right. So here, these are your endocrine medications to be familiar with. Then you got immune drugs or immune system drugs. So immune stimulants or drugs that energize the immune system. This could also be drugs that treat cancer, right? Drugs that treat cancer. So what I would recommend is, there's a lot of chemotherapy. There's a lot of drugs that treat cancer, but just be familiar with, for the sake of the test, try and learn some of their names. Like, for example, methotrexate. Some of them have very, very specific ending names. Like another one, mustine. That's like that's not the full name, but that's how it usually ends, like the ending of that name. So immune system drugs, they help to boost the immune system, because the reason why is because it's trying to fight, right, an infection, right, a prolonged invasion. And so they need help when fighting some type of specific pathogen or cancer cell. So it's one of the classifications of a drug class called immunomodulators. So immune systems are drugs that utilize to block the normal effects of the immune system in cases of organ transplantation and autoimmune disorders. So so you got immune stimulants, and then you got immune suppressants, right? Because the suppressants is when they undergo when they have an organ transplant done, right? So we have to give them these suppressants. And then immune stimulants, it's more so to treat cancer, right? Or I should say, a response for cancer, for patients that are on chemotherapy or chemotherapy medications. So interferons, interleukins, colony stimulating factors used to help stimulate bone marrow, so that way they can produce more white blood cells, especially for patients that are at serious risk for developing an infection.